Hello, everyone, and welcome to Africa Fire Mission's weekly virtual training session. My name is Mike, and I'm the programs director here at Africa Fire Mission, and we're so happy that you took time out of your busy schedules to join us for today's training. Today, we're joined by Eric Saunders. Eric heads up most of the EMS portion of what we do here at Africa Fire Mission. He's traveled with us to Kenya numerous times, and he's here to talk about updates to the BLS guidelines. They made some changes here in the last year. So we'll get you all caught up on that. But before we get started with today's training, I'm going to pass things over to Errol Sianga. Errol is Africa Fire Mission's fire safety advocate, and he's going to get us started with a few words of encouragement.
Thank you very much, Chief Mike. Hi, Eric Saunders. Welcome. Happy New Year. Also, remember to register yourself in today's virtual training, and we'll talk more about that. So today's devotion or encouragement comes from the book of Isaiah, chapter number 30, from verse 18. So a word of encouragement before we begin our lesson for today. It comes from the book of Isaiah, chapter number 30, from verse 18. And it says, "Yet the Lord longs to be gracious to you. Therefore, he will rise up to show you compassion, for the Lord is a God of justice. Blessed are all who wait for him." So all of us, we need to wait upon God each and every day. And as we work, as we do our duties, either in a workstation, at home, or in the community, let us always service we do, we wait upon the Lord and we seek him day in, day out. So that's our word of encouragement today, as also as we continue in the session for today. So thank you very much, Chief Mike. Over to you.
All righty, thank you, Errol. Before we get started with our training, let me just touch on a couple of administrative notes. If you stick around for at least 70% of today's training, which is usually about 40 or 45 minutes, you'll receive a certificate of attendance for today's training. If something happens where you get cut off, your network drops, or maybe you've got to respond to an emergency, no worries. There are some other ways that you can earn that certificate of attendance. If you head over to our webpage at www.africafiremission.org, go to the resources tab, and under training materials, you'll find a link to our Google Drive where you'll be able to watch videos of this class or any of the other classes that we've done so far this year. If you watch the entire video, answer a few questions to let us know what you've learned, I can get you a certificate of attendance for those classes as well. Just as a note, the name that goes on that certificate of attendance for today's class is the name that you're using on your screen, so if you need to make some adjustments to that, now's the time to do that. Also, if you've got some other people watching on your screen, it's a great way to save some resources. Go ahead and drop me an email. Keep your eye on the chat. I'll drop my email address in there. And let me know who else is joining you on your screen, and I'll get a certificate of attendance for them as well. When we get finished here with class at the top of the hour, we're going to transition over into our tea time. Tea time is a time where you can ask more questions about today's training, or you can just do some networking. You can see we've got firefighters from throughout Africa joining us here. So if you have the time in the bundles, I would encourage you to stick around for that. And now with that, I'm going to pass things over to my friend Eric here to get us started with today's training.
Hello, all. Can you guys hear me?
We got you.
Cool. So today what we're doing is we're talking about the American Heart Association updates that happened in 2025. One of the big reasons why this is important is as of next month, all BLS and ACLS and PALS trainings are going over to the new guidelines. Today we're focusing on the BLS proportion. And kind of getting into some of the changes and some of the important parts for the update that that the AHA has come out with. And so we really wanted to focus on this and just have a good reminder for all of us. We're not holding an actual BLS class for now. So I'm going in with the assumption that you guys already have this knowledge. If you don't, what it is it'll set you guys up for a good way to kind of transition into getting your BLS certification. But as of now, what we're going to do is we're going to assume that you already have some of that BLS knowledge. and then we're going to build upon that, focusing on the new guidelines. Go ahead, Mike. All right. So age identification. I just wanted to kind of reiterate this in that the three main age groups that AHA talks about. So infants are younger than 1 year of age, uh, and this is where, except for the newborns, so newborns are in a completely different kind of category called neonatals, and that's from 0 to roughly. And we're going to go into like a neonatal resuscitation program, and that's a whole different certification that I also recommend taking if you haven't taken it. But the guidelines are a little bit different. So infants are younger than 1 year of age. That's what we're going to be talking about today. Children, they range from 1 year of age, so after the infant age range, up to signs of puberty. And so that can include chest hair, arm hair under boys and girls, any breast development, anything like that. And then for children with signs of puberty and older, aka all of us adults, we would follow the adult BLS guideline. So that's kind of the cutoff age range for the groups that we're going to be talking about today. Go ahead. Oh. Next one. So this is the BLS guidelines for basic life support and CPR. One big new change that the AHA is kind of focusing on is the recognition of stroke in children. So they did a really good job about talking about stroke recognition in adults, but they never really kind of focused on the aspect for it happening in kids. Where this comes into play is that approximately 40,000 or so kids worldwide experience a stroke each year. And so they were missing a huge population of strokes in kids because we weren't really focusing on that. So we're trying to remind us as, EMS providers and uh, clinicians to look for the recognition of stroke in kids. And so you can see here in the common signs and symptoms what those are, but then also we need to activate EMS if we're not already EMS. And they should be transported to an emergency department. So roughly of those numbers, 60% are ischemic and 40% is hemorrhagic. And for a review, ischemic means that they have some kind of like a blood clot or a restriction of the arteries. And then a hemorrhagic stroke means that they have some kind of bleeding going on in the brain. And so there was one study that they kind of mentioned, and the study found that some kids had moyamoya disease, which is it's a fairly rare disease, but it's a constriction of the arteries in the brain. And what that happens is sometimes when there's blood clots in this disease, what can happen is then it can restrict the blood flow to the brain and then cause a stroke. For the hemorrhagic folks, that was about 40% of the population. It's a rupture of something called a cerebral arteriovenous malformation. And basically what that is a big fancy word for it's a abnormal connection between your arteries and your veins in your brain. And what happens is that can grow to be fairly large and that can rupture because the blood vessels are kind of weakened, and then that can cause a stroke for hemorrhage, for like a hemorrhagic stroke. And so they wanted to do that and kind of focus on these common signs and symptoms of stroke in kids and then get them to the ER so that we can potentially um, uh, catch them early on. So 60% of kids who have a stroke have a persistent disability. They have to live years with a deficit. And so if we can catch them early on, just like in adults, hopefully we can prevent that. Go ahead. And then, as many of you probably have seen a lot of these different kind of like the FAST for spotting a stroke, face, arm, speech, time. That's essentially what we in EMS would focus on as the Cincinnati Pre-Hospital Stroke Scale. We basically look for facial droop, we would look for arm drift, and then we would ask them to repeat a phrase, testing both memory and their speech. And so, kind of the new guidelines kind of focus on using these recognition tools as kind of guides that potentially could indicate that there's a stroke in our patients. Go ahead, next one. So seizures. So seizures are a pretty common medical condition. At least in the US, over 3 million have epilepsy. Uh, and then febrile seizures occur in about 2 to 4% of the population. Usually this is in the age range between 6 months and 2 years of age. And although seizures can be um, like pretty visually dramatic, they don't always require treatment from a healthcare professional. Where we would have to give, like, especially from like a paramedic or ALS standpoint, where we would have to give a lot of medications. Um, and so the big thing that we can do is protect these people, our patients, from experiencing a seizure from injury and calling a EMS an appropriate situation. So the guidelines kind of focus on that, where we should provide first aid and treatment as appropriate. So for kids who have experienced a febrile seizure, um, what the AHA has found is that the administration of antipyretics, so medications such as like acetaminophen or ibuprofen or paracetamol, it's not effective in stopping a seizure or preventing any subsequent seizures related to a febrile seizure. A big one that they also kind of reiterate, go to the next slide, Mike, is that they don't want the person who's having a seizure to be restrained. That can actually cause them more damage. We want to protect their airway, but we don't want to restrain them in such a way that could potentially hurt them more. We don't ever want to stick anything in their throat, anything like that. Um, and we in after a seizure, they are also in that postictal phase. So we don't want to do anything to that because they're in a kind of a decreased responsive um, phase, and they could potentially aspirate or choke. So we don't want to do anything like that either. Next slide. So AHA has updated their chain of survival, and if you've taken a BLS courses, this is one of the things that they like to focus on. And so it has guidelines, and then they updated it. The biggest change that they made is the first one there. If you guys can read that, it's recognition uh, and activation of the emergency response. And so basically, it's promoting the recognition of an actual emergency and then activating that EMS response. And so, as providers, we're part of that EMS response, or if we happen to be a layperson in the community, it's getting our friends and colleagues to come out to the scene to be able to help in that situation. And so they really kind of try and focus on that. The other ones kind of in the middle haven't really changed too much, but then they also, and we'll get into this later, also kind of talk about the recovery and survivorship. So that's a little bit different of a kind of a phrase that they're using nowadays for this kind of training and in the chain of survival. Next one. So this is where it differs a little bit. And so like in the newborn chain of survival, so the previous slide was focusing on kids and adults. And this one is focusing on newborns. And similar to like what I said already about like having that neonatal resuscitation, there is a big component on the newborn chain of survival on like prevention. And so a lot of times, especially in kids, and if you've taken like PALS or anything like that, we really focus on the prevention aspect because if we can do that, then we prevent the kids from worsening. And so there's a whole separate newborn chain of care that provides this kind of framework. And although it's not a big focus for the BLS, we may encounter these patients, you know, as especially as EMTs, that's one of our skills is to potentially help out in uh, a labor and delivery type of situation. And we need to know the initial steps at least to kind of facilitate that in case the infant comes out and we need to provide aid for them. Next slide. So the next kind of points on this slide are that AHA really wanted to kind of give an overall focus on the differences in the compressions, ventilations, and ratio. And it's you know, AHA is really big about the science behind all of the changes and everything. And Nancy and I and Dr. Henley, who has come with us on a couple of our trips, were at a cardiac arrest survival summit, and the AHA people were there, like the who's who of the people, and they were explaining all the science into it. We're not going to get it too much into the details, but basically we wanted to kind of focus on some of these changes. And what they found is in some of the studies that have been going on around the world with some of the top resuscitation uh, programs is that we as rescuers often don't deliver really good quality ventilations in accordance with the guidelines. And so we really want to make sure that when we are um, bagging our patients and we're giving good ventilations, we want to really focus on the parameters set forth in AHA. And so we don't want to, you know, say you have a big BVM, right? And so here we go. Aha. Got a big BVM, right? So on average, a BVM that we carry has about 11 to 1300 cc's of air in it. But the problem with that is on an average patient, our lung volume is anywhere between 4 to 600. So if we're completely depressing this bag, right, we're expanding our lungs over capacity and we're overventilating our patients. We don't want to do that. And so we just want to squeeze to give enough tidal volume to produce visible chest rise and fall. And so we should avoid hypoventilation. We should avoid hyperventilation. So we want to we don't want to overbag our patient. We don't want to underbag our patient. We want to have that good ratio, you know, every 5 to 6 seconds of bagging our patients or the 30 and 2 in the ratio, right? And so we really want to make sure that depending on what our protocols are and what our guidelines are, you know, some jurisdictions around the world are using high performance CPR where we're actually bagging through compressions, but AHA still recommends the 30 and 2 for those agencies that aren't in that high performance CPR. And so also with they recommend a placement of an advanced airway, so supraglottic airway, such as like a King Airway or an iGel, or the gold standard, which is also a ET tube. So we really want to focus on giving really, really good ventilations and also compressions. Next slide. So the next couple of slides, we're talking about pad placement. And so depending on what your AED shows, that's the placement that you want to have for your pads. And so if it has an anterior lateral placement, what they really want to focus on is having good placement. So we don't want to have both pads like kind of like up here on the chest. we actually want to have it almost off to the side. And so, because what we're doing is when we put the pads on a patient, the reason why we're doing that is we're trying to get a good angle so that the energy actually goes through the heart when we defibrillate or cardiovert our patients. And so we need to make sure that it actually gets to that. And if we have both pads on the top of the chest, well, that's only going to skim the heart. It's not going to go through the heart. So that's why we really want to focus on really good anterior lateral placement on the actual lateral ribs. And it should be not too high, not too low, right there where the pads actually show, kind of similar to this picture. Next slide. Uh, Also, we could do, and instead of interlateral placement, we can do interposterior placement. So a lot of the AEDs and the monitors that I use actually use this type of placement, and there's two types of placements for that anterior posterior placement. So you can see on the top here, placing one pad in the center of the chest, and then over on the back. And basically, what you're doing is you're sandwiching that heart, and so you're getting a really good quality kind of angle through the heart for that energy to deliver directly to the heart, and that's going to provide the best outcome to our patient. We can also do a little bit of a angle, so above kind of like the breast area, and then a little bit lower on the back, and having it at an angle on the like the bottom one seen here. That's also appropriate too. Next slide. So some really special considerations they wanted to try and focus on too is like this first one. So when we treat women, and this is really, really important, especially for people out in the community and stuff like that who are, and even as providers, we're we want to be respectful to women uh, and provide them, decency and stuff like that. And so instead of potentially completely removing the bra, what we can do instead is it might be reasonable, and they kind of focus on this, is to kind of just move it away and put the pads on under or around the bra, making sure that we still get really good placement. So if we're doing that AP placement, you can put it kind of under the bra and then do it that way. So we don't actually have to, completely expose our patient as providers. And they're kind of focusing on that. And so that we provide them a little bit of some decency, right? And it could mitigate some factors, especially out in the community where or like for us as providers, maybe some potential discomfort in, oh, we're going to expose this woman's chest. So they kind of wanted to talk about that. The next one is for patients who are really, really obese. And obesity is a problem anywhere, definitely, especially here in the US. We have a lot of obese patients, well over 100 to 300 kilograms. I transported a patient the other night who was almost 200 kilograms, so pretty large gentleman, and they wanted to make sure that there are some studies out there, and there have been some other trainings that there might be some special considerations for these obese patients, but we want to make sure that we use the same techniques that we would for any other patients on these obese patients. And there shouldn't be any kind of deviation from the actual AHA guidelines. And then also for infants and children, we really want to reiterate not having, or we want to make sure that we minimize the interruptions in CPR. So usually we're really good about doing this for adults. We don't want to pause any chest compressions for less than 10 seconds, but definitely for the kids also, we really want to kind of focus on that too. And kids add a whole element of stress because, oh my gosh, this is a kid, we don't want them to die, and so we really want to focus on providing the best care for them and focusing on not pausing compressions. Next slide. A big change this year is that we are no longer doing the two-finger CPR technique on infants. What they found is that the two-thumb encircling technique is far better. There's a bunch of research on that. So doing the full encircling technique is really, really important. And as you can see in the photo here, um, your hands aren't actually wrapped around the entire infant. So you don't want to actually compress the kid fully, like sandwiching them like this. You want to have them, your hands kind of off to the side, and then actually using your thumbs to compress the kid on a hard surface. Um, and then if you find that you can't do that well, say you don't have a lot of thumb strength or you start to get tired, what they found was they can also be it can be also be appropriate to use the sternum with the heel of one hand, just like we would for a little bit older kids, if we can't completely like encircle the chest. Um, so we are no longer doing the two finger technique. We are only doing the one hand or the two thumb technique from now on. So we're that's no longer recommended. Here is the adult BLS guidelines for CPR, and not much has changed. Everybody should be pretty familiar with this algorithm. And so the big one that they added, though, um, if you wanted to zoom in here, is that they're also focusing on um, the role of opioid antagonists. So such things as like Narcan or naloxone for suspected opiate overdose during respiratory and cardiac arrest. And so they want to kind of do that, especially here in the US. We have a pretty bad opiate problem. Um, I've had to treat many, many patients from this, but it's really important, and so they wanted to kind of reiterate and put in the role for the opiate antagonists in CPR. And so if you look off to the side there, there's no breathing, provide breaths, but then also it has if suspected overdose, administer the opiate antagonist. So Narcan or naloxone if it's available. So that's one of the bigger changes to the algorithm for the 2025 guidelines. Next slide. So this is some policy considerations. I know definitely there are some struggles in Africa and other developing countries that we might not have a lot of access to certain medications. We might not have a lot of access to, say, in other countries like in the US, like this. We don't have access to this opiate emergency kind of kiosk, similar to like an AED thing. But what they are recommending is for us to be advocates for these out in our communities. And it might be reasonable to go get one of these, and administer naloxone to our patients if it's a suspected overdose. Um, and then if it actually happens to be an actual opiate overdose and the patient comes back after the administration of Narcan or naloxone, what we've found is, at least I can attest to this personally in my community, this is something that we have instituted. And what we do is, so say we had a patient, they had an opiate overdose. We have resuscitated them. They're now conscious and alert and breathing. And what we do is either the police officers or the EMS facility will actually educate them and give them some uh, naloxone to have on their person in case that happens again. And then educate people around them if they have a drug problem to administer that so that it potentially prevents a patient from going into full cardiac arrest. And so, as providers, we can go into this and be advocates in our communities, into our government, into our communities, and try to kind of advocate for these kind of things to do. Same thing for AEDs. And so also for they kind of focus um, on public policies to allow um, good faith administration, similar to the Good Samaritan law, for lay people to administer Narcan or naloxone. Um, and we've seen a lot of good impact and cut down on some of our overdose deaths with this kind of legislation and policy. Next slide. So debriefing, they start to do this, and they talk about um, the importance of debriefing. And so I know I've had a lot of difficult calls before, and uh, this is something that I think is really, really important. And because um, mental health can have a really big toll on firefighters and EMS staff anywhere. It doesn't matter where you are in the world. It weighs heavily upon us, right? And so I've had people and friends who have committed suicide, and so I'm a really big advocate of talking about some of the difficulties that we face, talking to friends, talking to colleagues and stuff like that. And one of the tools of that I like to do is definitely the importance of debriefing. And so after a call, after a code that we run, it's really, really important to debrief afterwards as a team and for anybody who's involved. So say if it was out in the community, getting some of those community members who participated in, say, like if they were doing bystander CPR, get them in on the debrief. And AHA is talking about either doing an immediate debrief right after the code. Say if you had ROSC, or if you had if you didn't and you had to call termination of resuscitation out in the field. It's really, really important to have a debrief. But the studies have shown that it's appropriate to do an immediate debrief or even a delayed debrief if you need to. But that debrief is still really, really important. And so, working at the hospital where I do, any code that we have, especially in the ED, we immediately afterwards, after the patient is either has been either pronounced deceased, or if we have gotten ROSC and we've transferred care or the patient is stable, we have a debrief and we talk about the different points in the code, and everybody is involved. And so, like, say if it happens in the emergency department, everybody who is involved in that care. So sometimes the EMS staff from the fire department or EMS will come in and they'll talk about, like, hey, this is what we did prior to getting to the emergency department. And then this is what happened during the code at the hospital. This is what we did. This is what we tried. And it's a great learning uh, kind of environment. And there should be no judgment. It's like, oh, you should have done this. We don't. It's not meant to blame anybody, but it's used as, hey, how can we get better? What's something that we did really good? What's something that we can improve? Using positive kind of terminology instead of negative terminology really, really improves the overall system and what can improve us as providers for better outcomes for our patients in the future. They also, like we talked about in that chain of survival, is talking about arrest, recovery, and survivorship. And so there is a growing kind of recognition, especially from AHA and the communities, after a patient, you know, it potentially goes home, or they have a long hospitalization. And what they found is these cardiac arrest survivors may need long-term, ongoing, integrated medical care, medical rehabilitation. They might need caregivers, community support, Um, and what was really cool about um, the summit that Nancy and I were at is they it was we focused on a lot of these survivors. So not only were there people like me and Nancy who were medical providers and company representatives and doctors and researchers, but there were a lot of people who were either family members of survivors or survivors themselves, and they actually had cardiac arrest and were saved. And there was a girl who was a teenager and she suffered a cardiac arrest in school, and she was there speaking about that kind of stuff. And so it's really, really important to have that long-term support of these cardiac arrest survivors. And so HA is really trying to focus on that. Um, really good education, really good community support, stuff like that. Because there is a huge psychosocial involvement after this, because it's pretty heavy. And again, that whole mental health aspect is really, really important. Next slide. Um, one of the biggest changes that we've seen in a long, long time is foreign body airway obstruction. So this was huge. So for years, we've been doing back blows and chest thrusts for infants whenever they have a foreign body obstruction or they've been choking. What they've found in multiple ongoing studies is that um, if we actually initiated back blows on adults and children, they have a much higher improved rate of relief and fewer injuries compared with just doing the Heimlich maneuver and abdominal thrusts. And so now, a huge update for 2025 is that now adults and children are going to be getting those back blows too. And so what we're going to be doing is we're going to be doing 5 back blows for adults, and then we're going to be doing that Heimlich maneuver for our adults and children too. So we do the 5 back blows, then we go around them, and then we do a correct placement, just above the belly button, and then we do the Heimlich maneuver 5 times, and then we keep repeating that until the foreign body has come out or they've passed out, and then we have to start CPR. So that is that algorithm. Even though it says adult, if you go actually into the algorithms, it's the same for adults and children. And then for infants, it's the same, except for the chest struts are going to be the 2-finger CPR technique. Um, and so big changes for foreign body airway obstruction. That is now for the uh, populations that we have. So that was a pretty cool update, and that we've had to be teaching all of our people now in the CPR classes. So with that, Mike, next slide. Are there any questions? I know there was a lot to cover. Um, I think it's really, really important to talk about any of these changes that you guys might have. And if I can answer anything, I'd love to kind of open it up for discussion for anything you guys might have.
All right, the floor is open for questions. If you have a question, you can drop a question in the comments section. You can use the raise hand feature, or after I make a few adjustments here, you go ahead and just unmute yourself and ask your question. Got a question there in the chat. Repeat the rationale behind back blows for adults.
So the rationale between back blows and adults is what they did is they actually so HA is really big into the science behind stuff, and what they did was they had a bunch of studies that similar to like you have somebody who's like coughing and stuff like that, and we like pat them back on the back. It's similar to that. And what they found is if we actually administer back blows or back slaps as they call it. It actually has a pretty good indication of actually kind of loosening up that object and getting it out. And so by doing a combination of the back blows and the abdominal thrusts, the science behind that showed that it was an increased and improved rate of relief. And fewer injuries doing this technique compared to just the abdominal thrusts alone. Um, and if you go to the actual AHA website, you can actually Google or do like an internet search of some of the science behind it. I don't have any right here, but I have looked at some of the data, and I did listen intently into the presentation that they had. But there are a bunch of different scientific studies that they actually did, and they compared the data to the two different ones. Um, also for that. So I hope that answers that question a little bit more.
Another question from the chat. Uh, in what way can a negative comment affect the process of giving CPR?
Uh, um, so not necessarily, so you don't want to have a negative comment, but you want to put like a positive spin. So like instead of like say you're the CPR coach or you're the team lead for um the code, right? And so instead of being negative to the person and saying, you suck, do better, or like you're doing really bad compressions, um, give them a little bit more constructive criticism. Like, how can they improve? Okay, just like our some of the AEDs that actually give CPR feedback, right? That's really important. And so, okay, we need to hey, I noticed that your compressions, you're not getting really good recoil. So, hey, work on the recoil. Or your rate is too fast. We need to slow down. And a lot of it is the delivery of how you say it, right? And so we don't want to be negative. We don't want to be condescending. We want to be having positive, constructive criticism. Um, and so, push harder, push faster, great compressions. A lot of people, I myself respond better to positivity rather than negativity. So that's kind of the same kind of guidelines. And then same thing for in the debrief too. Like, like, oh, hey, don't point out like you can point out ways to improve, but don't like go up and say, hey, you did like this really badly. Instead, go about it a little bit different spin, like, hey, I noticed that our compressions could have been a little bit better. We really need to focus on that and maybe, hey, let's go do some training afterwards.
Um, uh, management of choking in pregnant or obese patients.
So that hasn't changed. Um, so for pregnant women, right, we're not going to go right over where the baby would be. So instead, we're actually just like in normal CPR or normal abdominal thrust, we're going to go above the belly and potentially to the chest. Same thing for obese patients. If we can't get our arms around them, like where their abdomen is, we can go a little bit higher. That hasn't changed at all. The only thing that has changed with these guidelines is adding those abdominal or those back blows.
Um, Couple questions related to the infant with the you
Mhm.
know so do you use that full arm when you're doing that, or do you use just some fingers when you for the infants.
Yeah. So the two ways that we used to teach the um, CPR in infants is we used to teach you had the infant and we would do chest compressions this way. What they found is a lot of studies have shown that that was ineffective because people weren't pushing hard enough or consistently. So they got rid of the two fingers, and either now it's compressing like this and with two fingers on the chest like this, or if you're not strong enough or anything like that, what you can do is you can use your palm and compress that way, but only a third the depth of the chest. So the same depth that you would want to do for the infants, but you're not like compressing the kid all the way. You're not using your full body weight like you would your adults because you don't want to do that for your infants, but you're still doing that so you're getting good uh chest compressions, making sure that you're getting good recoil, you're doing the correct depth and rate, right? And so that rate is 100 to 120, making sure that depth is one third the depth of the chest. Um, in adults, that's going to be 2 to 2.4 inches. But yeah, for kids, we don't want to use the two finger technique anymore.
With the thumb encircling technique for the babies or the infants, how do you maintain neck and head support?
Um, so what you can potentially do is the problem with kids, right, is they have that big old head, right? And so we they could potentially be, in an incorrect position. If we really needed to, we could put like a blanket or something behind them, up to their shoulders, and then we can compress around that. But we still want to have a hard surface under them, and so we're not necessarily, um, they're going to be on a hard surface. We're not holding the babies and doing that so that their head is just going to flop around. We want to make sure that we're compressing them onto another hard surface, just like we would with an adult. It's not like an adult where we're doing this to them like in the air. We're not going to do that with the infants. We need to make sure that they're on a hard surface, and that's when we're compressing. So we're compressing their chest with our fingers and into the harder surface. So because they're on that hard surface, their head and neck are already supported.
Uh, at what point are we supposed to start CPR when you suspect internal bleeding?
Um, so it depends. So this is where we go back to, if you suspect internal bleeding, but they don't have a pulse and they're not breathing, then we start CPR, right? There's no difference between a traumatic arrest and a medical arrest if their heart is stopped. And so we want to get that started. Now, this is going outside of the BLS guidelines, right? And that if there's a traumatic arrest, like ultimately they need surgery. We can't provide that, but we can potentially beat their heart. And so if they have no pulse, if they're not breathing, we start CPR no matter what their injuries are.
Uh,
And so yeah, so we can't really focus on, oh, we suspect this injury, this bleeding. Now, if they have major bleeding, like say for those of you who have attended our active bleeding control, with some of our providers and stuff like that, if they have like a severed arm, put a tourniquet on that and then you start CPR, or have somebody else put a tourniquet on there, because otherwise we're just going to be spurting the blood out. So stop major bleeding. We can't worry about internal bleeding, but we do want to start CPR right away.
if one has a hole in the heart, is it okay to do CPR?
Um, yeah, um, probably won't do much, but that's an appropriate thing to do. Um, we want to try and we. What happens is ultimately our body needs to perfuse the blood, and so if our heart, the pump, isn't circulating the blood, that blood has to be circulated somehow. And so that's one of the things that we need to do for them. Now, if they have a hole in our heart, well, maybe if we're pumping it with our hands, we might be occluding that somewhat, but um, that's a really hard thing. And a lot of times that would end in termination of resuscitation. But we still want to do CPR.
To really basically simplify things and boil it down, if the heart is not pumping, we need to pump it for the
Yep.
person, irregardless of what else is going on with the person.
Yep. If they have no pulse, if they're not breathing, we want to start CPR.
Timmy, I saw you had your hand raised. Are you able to ask your question?
Thank you for the session. The question that I had was about the special people, the ones who are either obese or pregnant, if you are still doing the back slabs for them, since choking patients, they have changed for the adult. That was the question I had, but I guess half of it has been answered. The other thing that I wanted to add on was about the feedback, how it affects CPR is, in short, a good feedback motivates the rescuer. A bad feedback demoralizes the feedback. So negative feedback will not make the rescuer to put more effort or to improve. However, positive feedback will make the rescuer to improve and even do it more cautiously. Thank you.
Thanks, Timmy. Uh, if we've got a patient with a spinal problem, can we do back blows?
Um, so it depends. So um, it depends what the spinal injury is, right? So if they're choking, we need to get that out. But if they are suspected of a spinal injury, that's actually a really good question. Um,
But big picture, if the
is you
person's
need to
not
get it out,
breathing, they're going to die.
right?
So we have to fix that problem.
hmm And the same thing with abdominal thrusts is you're going behind them and you're with their you're where their spine is and you're causing them their spine to move. Like Mike said, is you need to get that out because if they don't, you know, um, if they're not breathing, they're gonna die. You can still live with an injured back.
Uh, I'll get this next one. How do you conduct CPR on a patient whose heart is pumping too fast? You do
Um,
not, because their heart is pumping. Remember, if they've got a pulse, you don't have to do CPR. So, if
so
they've
make
got
sure
any
that
other
you're
sort of
doing a good assessment.
complications, yeah.
We only do CPR on a dead person. If their heart's going too fast, that's when we need to go into ACLS and we would provide either medication or um,
Yeah.
electrical therapy.
Uh, do you guys have a question?
Yes.
Go ahead.
Okay. My name is Stevenson Ohinesafu from Ghana National Fire Service.
Hello.
Yes, my question is, I would like to know the duration a rescuer is expected to give CPR to a victim until the time of recovery. That is the first question. Like, how many minutes does a rescuer have to bring the person back to recovery? Then the second one, is there any medicine to avert the possibility of having stroke after recognizing the symptoms?
So yes, so both of those I can answer.
So these are my questions.
So CPR, um, it goes in a round of 2 minutes. Providers should be going for 2 minutes. There is no end of a duration of CPR unless two things happen. Either you get ROSC, so a return of spontaneous circulation, so you just saved your patient, or you get another advanced provider there So a doctor or a paramedic or somebody who's actually able to determine and call the termination of resuscitation. So those are the only two ways that you would stop CPR. Um, I've been a part of a resuscitation for over 2 hours. Now, I'm not the one who's doing CPR for the full 2 hours. I have a whole team doing CPR, but there has been good outcome. We had a patient a couple of months ago who received CPR for over an hour and a half. Um, and they had good return of spontaneous circulation, no neuro damage because of the excellent CPR that was provided, and they have a good outcome right now. So there's no way to cease CPR unless you're going to terminate or you're going to you actually get a pulse back. And then what was the second question, Mike?
I didn't catch the end of it. It was about a medication.
Oh yeah, medications for strokes. Um, so that's not something that's in the BLS guidelines, but at a stroke center or at the hospital, they can give multiple different medications. One's called TPA or TNK. Those are two different medications that we could potentially give. They're kind of like clot busters. At some stroke centers, if it's a comprehensive stroke center, what they can actually do is they can actually go in and then they can actually go in and with small cables actually go in and pull the clot out. So there's a couple of different medications that we can give, but also in some of these really high-end hospitals, they can actually go in and remove the clot too. So there's a couple of different ways, but that's why it's really, really important to get these stroke patients to a hospital so that they can get that higher level of care.
All
That was a
right.
good question.
We've got a couple more questions, but I'm going to wrap up the formal portion of our training. Stick around, everybody. We're going to get to these questions. We're just going to end the recording right now. So let me wrap things up first with a thank you to Eric for coming and sharing his knowledge of the subject with us, getting us updated on some new ways to look at things and keeping our skills nice and sharp. So thank you, Eric, and also thank you to all of you that you're using your time, your bundles. Some of you guys in Ghana are on shift. That's awesome seeing all of you guys here.
Yeah, it's really
We
encouraging.
really, yeah, we really we don't take it for granted that you guys are joining us and trying to better your skills so that you can better serve your community. So we really appreciate that. If you find that there's other people that may benefit from these trainings, please feel free to share the registration link. We've also got a bunch of free resources available on our website, www.africafiremission.org. Go to the resources tab. There's all sorts of good information there covering a variety of topics: fire safety, fire prevention, even some first aid and active bleeding control. Lots of good information on there. So please go ahead and check that out. And with that, we're going to wrap up the formal portion. Stick around for our tea time. We'll continue with the questions. Thank you, everyone, and we'll see you all again next week.